Thank you very much for the introduction. Salam alaikum. Is this correct? I don't know. My Egyptian is very bad. So really thank to the esteemed colleagues and to Amar for inviting me here. It's a real honor being here with you and with the professor who presented me and with Professor Ashina. In the next 25 minutes, I will provide you another sometimes hidden facet of migraine. And it is a different type of headache. It is called medication overuse headache. And it belongs to the secondary types of headache, but you will see that it is very, very closely related to migraine. Also to tension type headache, but mostly to migraine. And it is really a severe condition that needs to be prevented if possible. If it is not possible to prevent it, because sometimes we arrive there when it's too late, when the patient is already overusing, at least it needs to be treated properly. Here you can see the potential conflict of interest in the past 2 years. And what is medication overuse headache? It's very easy to diagnose because it is a headache that is present on at least 15 days per month for at least 3 months. And the patient on some of these days has to be using acute medication. You see, at least 10 days per month when we deal with the use of triptans, ergots, combination analgesics, or opioid-containing medications, or at least 15 days per month using acetaminophen or non-steroid anti-inflammatory drugs. And this has to be going on since 3 months, but in most of the cases in our center we see this patient when this has been going on for years, sometimes for decades. And another important thing, the condition sine qua non, we can say this is a medication overuse headache, is that there is a pre-existing primary headache, and in more than 70% of the cases it is migraine. So this, for some of our area, medication overuse is just a complication of migraine. It's not a separate headache. And what happens here is a paradox, because we have a patient with attack. The patient is taking a medication, and the medication is inducing relief, but then migraine returns. And so the patient is forced to take other acute medication, but taking the same medication several times is going to reduce the efficacy of that medication. So the patient is experiencing less relief. And at a certain point, the patient will transform from a patient with episodic migraine to a patient with chronic migraine. And at that point, maybe there is medication overuse. So the other diagnosis that we have to give to this patient is medication overuse headache. But this is a sort of vicious circle, because the patient has an increased frequency of migraine attacks, and this leads the patient to increase the use of medication. And so more frequent attack and more disability. So really medication overuse headache associated to migraine is a very disabling condition. And for many patients, it is what I call a stairways, not to heaven, but to hell, because we have patients with episodic headache, I said migraine, most of the cases. They start to use acute medication to be in control of their attacks. And here is the stairways. They move, they transition from episodic migraine to chronic headache, which is less responsive to treatments. And there are many factors. We will look at some of them. There are many factors that can be involved in this transformation. Genotype, predisposition, life events, certain types of personality. What happens, what we think it happens, is that the system goes toward sensitizations. And this is a very important problem that, and as you can see, 77% of the patient, they had a migraine, an episodic migraine. They are women, in most of the cases, young women, and during the active phases of life. And in most cases, they take drugs to be able to take care of the family, of the work, of all the relatives, of the problems of life. And is it a small problem? I don't think so, because you can see here the prevalence in the general population of medication overuse headache. It ranges, depending on the studies, from 1% to 2.5% of the general population. So you take 100 people, there is at least one who is suffering from a medication overuse headache. And it is even a bigger problem in specialized centers, where you can see from 10 to 50% of the patients, they come to us and they are in a condition of medication overuse headache. And is it less of a problem for Egypt? I don't think so, because I found this paper that is relatively recent, showing that 77.5% of the general population, they qualify for medication overuse headache. So it's definitely a problem that you might also have here. And here is a relatively recent paper showing the drugs that are used by patients with migraine. And as a difference from Italy, in Italy, patients more frequently, they overuse from triptans. In this case, I see that triptans only represent 1% of the drugs that are used by patients with migraine. More frequently, patients, they do use analgesics or anti-inflammatory preparation, ergot preparation. 21%. In Italy, ergot drugs, they are no longer used since we have the triptans, but of course it depends on the availability of drugs. And then 90% simple analgesics. And now you may ask me, is there a class of drug that is more frequently associated to medication overuse headache, that is associated to a higher risk of evolving toward medication overuse headache? I'm showing you a revision of the literature that was published recently, and looking at the different papers that evaluated medication overuse headache and comparing the different classes of drugs, you can see that there is some difference between classes. Here on the left, triptans versus analgesics, you can see the diamond there seems to suggest that triptans are a little bit less associated to a risk to develop medication overuse headache. Triptan versus ergots in the middle, the diamond is exactly in the middle, so there is no class that is less risky or more risky. Triptan versus opioids, it seems that triptans, they are associated to a lower risk of inducing medication overuse headache. If we continue along this line, we can compare ergots versus analgesics. Again, it seems that ergots, they have a lower risk. Ergots versus opioids, more or less the same. Analgesic versus opioids is the same. This was an information that came as a surprise to me, because we always think that opioids are more associated to the risk of medication overuse headache. Fortunately, opioids are not frequently used, at least in Italy, but looking at this analysis of the literature, it doesn't seem that there is a higher risk. But the bottom line information that I want to give you, it's not a systematic research, but it's the data that you gather from the literature, is that bottom line, all symptomatic drugs, if they are used in excess, they can induce medication overuse headache. So this is a very important information. And now we go to the medication overuse dilemma. Is the overuse of acute medication the cause of medication overuse headache, or is it the effect? I think that both hypotheses are correct, because we know that overuse of acute medication worsens the primary headache. There is a lot of data, a lot of evidence in the literature showing that you stop overuse medication in patients who are suffering from medication overuse headache, and 60 to 70% of them, they do improve. So definitely there is a cause-effect relationship in that case. But we also know that it is possible that a very aggressive type of migraine is inducing the patient to overuse acute medication. So I think that we have to consider both variables when we think of the pathogenesis of these patients. And I'm giving you some insights about what we know of the pathophysiology. I'm not telling you everything, because I would need like 2 hours. I will not talk to you about neurophysiology, neuroimaging. I will give you some insights from basic studies and some from preclinical studies conducted in patients. So from basic studies, I'm showing you this is a very interesting study that was performed by Milena De Felice when she was working with Fran Porreca. And what she did is she gave chronic triptan to rats over several days through a pump. And then she evaluated the threshold to mechanical stimulation delivered to the face, trigeminal nerve, or delivered to the hindpaw. And you can see that there is a nice reduction of this threshold, meaning that the rats did become allodinic. And the experiment was repeated, was done with sumatriptan, and it was repeated with another triptan, naratriptan, and more or less we have the same picture. So the rat exposed to triptan, of course it is not a migraine rat, and rats, they do not have migraine, but anyway, the rats exposed to triptans for several days, noxious system is altered. They become allodinic. They perceive stimuli that are not painful as if they were painful. And then there is another study that is more recent and adds a little bit to the information we have. Here again we have rats that were exposed to triptans, sumatriptan, for several days, and again you can see that in both areas there is a reduction of the threshold. So again the rats become allodinic. When you stop the chronic administration of the sumatriptan, you see that the situation is returning to the normality, and this already is an information. And if you expose these rats to light stress, remember that patients with migraine, they do have photophobia. Okay, you expose them to light stress, they have again a reduction of the threshold. They become again allodinic. And you expose them to nitric oxide donor. Nitric oxide donor is a model of an animal model of migraine. It is also a human model of migraine that we have been used in Masood in particular. And so you expose them to the nitric oxide, and again you have this type of response. So this system is basically mimicking very well allodynia that patients with medication overuse and migraine, they do develop when they become chronic. And it's also mimicking very well the latent sensitization that we think that these patients, they do develop. And as an addition to this, you can see that in these rats that were exposed to chronic triptans, there is an increase in the activity of nitric oxide synthase, which means that they release higher levels of nitric oxide. And another information that you can have here is this is a section of the nucleus trigeminalis caudalis overact that was exposed to chronic treatment with, you can see that LY344 is lasmiditan. It's one of the new drugs for the acute treatment of migraine that will be released in Europe probably next year. And you can see that the chronic exposure of the animal to this acute medication again is increasing the staining, so the levels of calcitonin gene-related peptide, which is an offending neuropeptide. Probably Masood will tell you more about this. And we also know one of the molecular mediator of this activity, because in 2019 there was this nice paper that was published, and it was about NaV19. What is NaV19? It is a nociceptor-specific voltage-gated channel that generates a persistent current that promotes sustained neuron activity in dorsal root ganglion neurons. And the experiment was very similar to the experiment that I just showed to you by Milena De Felice and the other group. This group, they exposed the animal to chronic sumatriptan, and they evaluated again the tactile withdrawal threshold. Again, it was a mechanical threshold. And you can see that the exposure to sumatriptan is reducing this threshold very much. So the rats becoming allodinic. They repeated the experiment in rats that were mutated, and this animal, they didn't have this channel. The channel in this case was not working, and you see that there is a nice reduction of the allodynia induced by chronic exposure to triptans. Now I'm switching to preclinical data. And I will tell you about this system, the endocannabinoid system. We have been working on it for the past 10 years. And it is quite a complicated system. I'm showing you a simplified view and just focus on this part. One of the endocannabinoids that our system is producing in conditions when it is required, and usually it is when we are exposed to pain, it is to synthesize on demand these endocannabinoids. One of the main one is anandamide, the other one is 2-AG, 2-acylglycerol, but we will talk about that later. Okay, so anandamide, you can see here that it is synthesized from a substrate through an enzyme, it's a NAPE-PLD, and then it is catabolized via another enzyme. It's the one that you see here indicated as FA. It's a hydrolase. Well, now we are going to patient with medication overuse. And in this group of patients, our center was like 30 patients with medication overuse. We evaluated at baseline the levels of the hydrolase, the enzyme that is catabolizing anandamide, and then we evaluated the electrophysiological threshold of the pain. Okay, we equaled it to 100, and then what we detoxified the patient, and this is the result that we obtained. There was a nice reduction in the hydrolase, meaning that probably the patient were having higher level of anandamide because anandamide was no longer destroyed as it was before, and also there was an increase in the threshold, in the pain threshold, so the patient were less exposed to pain. And this was true 10 days after the withdrawal from acute medication, but it was also true 60 days after the withdrawal. So it is an offending situation, but it is a situation that can be reversed. And now I'm switching to the other part of the endocannabinoid system, 2-AG, 2-acylglycerol, and again we have a synthesizing enzyme, DAGL, and we have a catabolizing enzyme, MAGL. Just keep in mind DAGL and MAGL, because in the next slides I'm showing you the data we have not published, but this is these are the levels of the two enzymes in peripheral blood mononuclear cells of patients with chronic migraine and medication overuse. And also you can see patient EM is episodic migraine. And we evaluated the patient, in particular chronic migraine medication overuse at baseline, and you can see that both of the two enzymes levels are higher in patients with chronic migraine and medication overuse. You can see in the blue columns. Then we detoxified the patient, and look what happened. There was a nice reduction of the level of the two enzymes. This suggests that the system is hyperactive in the patient with chronic migraine and medication overuse, but when you detoxify them, you basically bring them back to normality. It is a different normality because it is a normality that is similar to episodic migraine, not to the control, but it is a reacquired normality, which is good. So, trying to summarize the little bit amount of data that I'm giving you today, what happens, what we think it happens in patients with migraine and medication overuse headache is that during the attack, the interictal period, when they are headache free, they may have a normal or slightly increased CGRP, nitric oxide levels. Probably they are slightly, and you have seen them, endocannabinoids level. Then they have the migraine attack, and during the migraine attack we know that there is an increase in calcitonin gene-related peptide, in nitric oxide synthesis, and we know that there is a decrease in the endocannabinoid tone. But then when the attacks, they keep repeating and the patient is taking acute medication, so we are moving toward the right of the slides, so we have patient with chronic migraine and medication overuse headache. At that point we know that the levels of CGRP are increased, as increased is the synthesis of nitric oxide, there is a decreased endocannabinoid tone, and this also alters the endogenous pain control system, the descending system for the control of pain, and the patient is in a condition of persistent sensitization. So how do we treat this patient? I think that there are three pillars that we have to follow to help this patient: prevent, educate, and treat. Prevent and educate, they go together, hand in hand. Because the first question we should ask us, but you already know the answer from the data that I showed to you, is that, is medication overuse headache preventable? And yes, I think yes, it is. And where do we start? We start by educating the patient. To avoid to overuse drugs is not easy because they are not taking acute medication for having a pleasure. They are just taking acute medication because they need to go to work and they need to stop the very disabling symptoms. Educate the patient to identify and avoid the triggers. We know that there are some things that can worsen migraine or they can induce migraine attacks. If they can be avoided, the first thing we should do is to try and avoid them. And to use different compensatory modalities. For instance, with stress, if they are living a very stressful life, they need to find some modalities to reduce the levels of stress. Then we have to educate the doctor and the patient, both of them. They have to contribute to identify and address the risk factors for the negative outcome of migraine. And we have a long list. We have obesity, we have snoring, sleep disorders, excessive caffeine intake, psychiatric comorbidities, lower socioeconomic status, comorbid pain disorders, history of head or neck injury, cutaneous allodynia, and major life events. Not all of them, all of these we can change, but some of them we can change. Together, if we do an alliance with the patient, we can change them. And then educate the doctor to optimize acute treatment. Remember that patients with medication overuse, in most cases, they suffer from a very aggressive type of primary headache, and I say migraine. And in general, they are the highly functional type patient. They don't want to stay in bed. They don't want to waste part of their life. They want to go out and work. They want to go out and take care of the tasks that are theirs. So sometimes it is important for the doctors to teach them to treat attacks early, before the cascade of events that is underlying the attacks is fully blown. So treat the attacks early, combine drugs if it is required. If these patients, they do have very intense attacks that if not treated properly, they last 2 or 3 or 4 days, just be more aggressive in the treatment that you prescribe to them. And if available in your country, you may also use and associate the neuromodulation devices that have proved to be effective for the acute treatment of migraine, because they have never been associated to development of medication overuse headaches, so they can help save drugs. And another thing that doctors should remember is that they should prescribe preventive treatment. And it seems Laplacian, but it is not, because the data that I'm showing you, the CAMEO study, it was conducted only a few years ago. And if this is the perfect world where a patient with high frequency or chronic migraine goes to the general practitioner for consultation, the patient receives the diagnosis and is prescribed preventive medication and acute medication. In the real world, what happens is very different, because from a very large number of patients who qualified as a chronic migraine patient, only 40% of them, they actually sought care with the general practitioner, and only 10% of them, they did receive the correct diagnosis. And look, only 4% of them were actually prescribed acute and preventive medication. This means that doctors, they do not use preventive treatment enough. So, how do we treat? These are the guidelines that have been developed with the European Academy of Neurology, and they were published a couple of years ago. And basically, they tell you that patients with frequent headache or medication overuse headache should be educated, and we have been there. To avoid the medication overuse, preventive therapy for headache should be initiated, and there are a few drugs that have been tested in patients with medication overuse headache. I will show you in the next slides. And in patients who fail advice and preventive therapy, withdrawal of the acute medication overuse is indicated. And here I'm showing you some of the data that showed that patients with medication overuse headache, if exposed to withdrawal, they have an improvement. This is the data from the Comoesta studies that we conducted with other centers in Europe and Latin America. And you can see that using withdrawal plus oral preventive medication, there were not monoclonal antibodies at that time, you see that patients, they move from 23 days of a headache per month to 9. And this is the number of days of use of acute medication from, again, 22.9, 23, they go down to 5.6. So 73% of the patients, they stop overuse, and many of them, they did improve. This is another study from the Danish group where they compared withdrawal plus preventive medication, preventive alone, or withdrawal alone. All the three approaches, they did work, but it seems that withdrawal plus preventive treatment was a little bit more effective, and you can see that 74% of the patients, they became episodic within 6 months, 87% no longer overused, and the patient cured, no longer overusing, with an episodic pattern of headache were 96.8%, the almost totality of them. So this is something that tells you that these patients, they can be treated. These are the drugs I was mentioning before. Only for these drugs, there is evidence that the medication overuse headache is improving. You see, topiramate was tested in patients with chronic migraine, including those with medication overuse. On botulinum toxin, in the PREEMPT program, patients were tested with chronic migraine and medication overuse, and it did work. Monoclonal antibodies, they have been extensively tested in patients with chronic migraine, also including those with medication overuse, and they work. I'm just showing you one of the multiple studies. This is on fremanezumab, and you can clearly see that when you stratify the patient by medication overuse present, medication overuse not present, you see that the efficacy does not change. The efficacy is there, and you can see that patients with chronic migraine with medication overuse, they reverted to non-medication overuse in 60%, 55, 60% of the cases. So this is another option. And this has probably a little bit influenced the management of medication overuse, because in the pre-monoclonal antibodies era, there was a sort of confusion. Some of us, they did the detoxification before, and then we prescribed preventive medication. Others, they did the advice and education with or without preventive medication. Now, in the era of the monoclonal antibodies, we tend to move toward a more linear approach. Advice and education is given to all the patients. Then preventive medication in general is given to all the patients. In case of failure of a preventive medication, then we detoxify the patient. And here I'm showing you a very algorithm, because I know I've given you a lot of information. So sometimes algorithms, they do simplify things, and it is something that has not been yet published, but it is an effort that was conducted by an Ashina, not Masoud Ashina, another Ashina, Said Ashina, because sometimes intelligence and dedication runs in family, you know, not always, but in some cases it does. And so he took over this effort to prepare this review on medication overuse. It has been accepted on Nature Reviews, and there is embargo for now, but it will be published very soon. And so you can have this situation. You have patients with medication overuse, and because sometimes medication overuse is there even if the number of days per month is not above 15. In that case, you cannot say it is medication overuse. You have patient with a high frequency migraine with medication overuse. Then you have patient with medication overuse headache. And what do you do in this case? Advice and education. This is the first step, and it's mandatory. Then, is the patient willing to discontinue the overuse medication? Okay, if yes, you move on with medication discontinuation under physician or nurse or psychologist guidance. Then in combination with preventive medication, and this is recommended, and you can use the monoclonal antibodies if they are available, but you can use botulinum toxin, topiramate, or even other preventive medication for episodic migraine. And then remember that these patients, they need long-term preventive therapy, including non-medical treatment, and they need follow-up, regular follow-up. They do not want to discontinue, no problem. You can start early preventive medication, and if incomplete response or ineffective, maybe you can propose them as a second step, the medication discontinuation. You may have also patients with complex medication overuse headache, those overusing barbiturates, those with comorbidities that are important, those who have already failed the preventive treatment without discontinuation. In that case, what we suggest is a multimodal pain therapy and medication discontinuation under physician. Okay. I will stop in 30 seconds. Okay. Under physician, again, nurse, psychologist guidance, in these patients, sometimes it is important to do the detoxification during the hospitalization, and then, again, they enter in the final box. Just consider that in some patients, they may have a withdrawal syndrome, so they have the typical symptoms. They may have headache, nausea, vomiting, arterial hypertension, tachycardia, sleep disturbances. So you have to take this into consideration. It is usually shorter with patients overusing triptans. Patients who overuse ergots and triptan, they usually develop very intense migraine attacks. And just remember that the patient with overusing barbiturate-containing migraine drugs, in some cases, it is very rare, but in some cases, seizures and hallucination have been reported. That's why sometimes we hospitalize patients. And use headache diaries, paper, Excel, app, everything is available. So headache diaries are your companions during the treatment of this patient. And for those who fail withdrawal, remember to offer a multidisciplinary approach. With different experts, it seems to be an increased use of resources, but it also improves the outcome. So it's not an easy path, I am aware of that, but it is extremely rewarding. I read that in your welcome message that Casar El Alani was the place where patients with no longer hope for the disease were received. In this case, the patient, they do have hope, and you can make a change, you can make a difference. And here is a picture that we have taken during the strategic meeting of the International Headache Society that we had last year in May. And I say here, we are the International Headache Society. I, Masoud, Amr, but all of you are International Headache Society, because you can see that the International, Headache Society has, okay, it's gone, has 54 affiliate societies, and the Egyptian Headache Society is also part of it. And the last slide, just to thank, was to thank my co-workers, the less young that you can see here, and very young. This is a picture that was taken at the European Academy of Neurology. Thank you for having me, and I hope you enjoyed the information that I gave you, and that you will apply to your patient with medication overuse headache.